Hi again, everyone. So this is going to be a talk on the acute coronary syndromes, and some of this is going to be quite similar to what I talked about in stable angina. So I might skip over that bit fairly quickly, and you can go to that talk if you want to know more about those things. And acute coronary syndromes is basically um, a group of diseases, 3 diseases, and they're all sort of a step forward from stable angina. So we'll take a look at those now. The 3 types are unstable angina. So stable angina, like I described in the stable angina one, is angina, which is chest pain that relates to the heart, that goes away when you rest, and it comes on during exercise or some kind of physical activity. And when I say exercise, that might not necessarily be going for a run. It might just be going and walking up the stairs or something. And unstable angina is not an infarction. It's unstable angina is where there's some ischemia, which causes pain, but those myocytes haven't actually died at that point. So there's some obstruction of the coronary arteries in some way, and that's led to ischemia. If that happens to lead to some infarction, which means death of myocardial infarction, death of myocytes, then you can get either an NSTEMI, a non-ST elevation MI, or a STEMI, which is an ST elevation MI. And those 2 terms, ST elevation or non-ST elevation, just refers to on the ECG when you see the ST segment, which is between the QRS and T wave. When you see that rise, that means ST elevation. And ST elevation is generally considered to be a bit worse prognostically than non-ST elevation MI. Unstable angina and non-ST elevation MI are both treated very similarly, and I'll show that a bit later on. So the causes are very similar to, they're basically the same as in stable angina, except for this time the obstruction of the coronary arteries is more so to cause these kind of symptoms. So there's an oxygen demand mismatch. There's not enough oxygen for the myocardium to work properly, or enough nutrients, glucose, and so on. And this might be because of coronary artery obstruction. The coronary artery obstruction needs to be 70% or more before symptoms even begin to come on. So you can imagine that for there to be unstable angina or an MI, there actually needs to be some very significant obstruction, more than 70%. So the most common causes of coronary artery obstruction are atherosclerosis, which is native to the coronary arteries, where they have a build-up of plaque from cholesterol and inflammatory responses and so on. Or emboli might form from thrombi elsewhere in the body, in the arterial system, and manage to lodge its way into the coronary arteries. More rarely you can get these acute coronary syndromes from these 3 causes I've got lower down on the slide. So vasospasm, which is unusual. You can get it from cocaine use, smoking, from cold weather, and it's very difficult to diagnose because, as you can probably imagine, a vasospasm is something that tends to come and go. So it's not something that you can generally tell is going on. You'll just see the results of it. The vasospasm is quite rare apparently. Trauma, you might find that someone's been traumatically injured to their heart, some chest trauma that's caused some myocardial infarction. Or probably one of the worst things that can end up happening is an aortic or coronary artery dissection. And an aortic dissection results in 50% mortality before that patient even gets to the hospital. So that's a disaster. It's all very bad, but this is especially bad. A dissection is where you have a tear of the intima away from the media in an artery, so that's the inner layer and the middle layer which tear apart, and you have blood that fills into the space between those two layers of the artery. You have three layers to arteries: intima, media, and adventitia. Adventitia is the outer layer. So between those two inner layers, you get this kind of false lumen, it's called, that gets created, and that can obstruct the coronary arteries because they run off of the aorta. Or the dissection can actually tear back into the coronary arteries, or it might even start in the coronary arteries. And if it tears in a certain direction, if it happens to tear into the right coronary artery, that right coronary artery supplies the sinoatrial branch, the sinoatrial artery, and if that gets torn into, that can damage the sinoatrial node, which is the pacemaker for the heart's rhythm. So if you get damage to that from a dissection or in any other way, you can end up with a bradycardia. So it's possible, if you have an aortic dissection or a coronary artery dissection, that you see a bradycardia. And you have to watch out for those, because if you end up giving someone, or if you want to give someone beta blockers, which is one of the treatments I'll talk about later, after this person has gotten over their initial hurdles and given the emergency treatment, then a bradycardia is a contraindication for a beta blocker. So some of the exacerbating factors, things that can make the symptoms worse or make the ischemia worse to the myocardium, these things are anemia, where the blood's not able to carry as much oxygen as it would ideally do, and where there's less oxygen, there's more ischemia and more pain. Left ventricular hypertrophy means that there's more of a demand for the myocardium in terms of oxygen and nutrients, and anything that increases afterload, left ventricular afterload, can cause left ventricular hypertrophy. So, and it could be the same for the right ventricle, I suppose, but it tends to be the left that we're talking about. So aortic stenosis or hypertension, anything like that, raises the left ventricular and diastolic pressures and means that it's more difficult for the blood to flow out into the periphery, into the aorta, so the muscle has to hypertrophy to pump it out against those high gradients. Thyrotoxicosis, the thyroid regulates our metabolism, so more thyroid hormones means a higher rate of metabolism, and a higher rate of metabolism requires more oxygen. So that can also lead to worse symptoms or more ischemia. Emotional or physical stress, or any kind of thing that makes your heart beat faster, basically, raises the demand of the myocardium again. So the symptoms. If you ask a patient how their chest pain feels without leading them in any way towards this, they'll tend to say that it's a dull or crushing pain, or use words to that effect somehow. And this is kind of this is different to other pains. For example, if they feel a sharp stabbing kind of pain, that can be very different to a dull or crushing pain, which is more related to angina. So a sharp stabbing pain, for example, when they breathe in, tends to get called pleuritic pain, which is usually related to the pleura, which might be something like pleurisy or something going on in the pleura that relates to the lungs, which is completely different. So the nature of the pain is very important, and it tends to be, like I said, dull or crushing, just behind the sternum. It might radiate to the left jaw or arm, it doesn't have to, but it might. And the pain tends to last for hours. It's not something that just goes away after a minute or two, especially in acute coronary syndromes. It might go away if it's stable angina and they rest, they sit down and they relax, and it might go away after some time. Even then, generally, I think it would usually last quite a while. But in the acute coronary syndromes, the pain, unless you're able to relieve it with GTN or some kind of treatment, the pain doesn't tend to go away anytime with rest. It might go away with time, but it won't necessarily go away with rest. Syncope or fainting, that that basically is just related to a reduction in cardiac output. If there is ischemia going on in the myocardium and it's not able to work as well as it should be able to, is to be able to pump as well as it should be able to, then there might not be enough blood going out of the aorta and then to the common carotids, so there might therefore not be quite enough blood to sustain consciousness. Dyspnea on exertion is I'm not sure if that's related to other things, but I'd imagine that's mostly just to do with a bit of pulmonary edema, because the cardiac output is reduced, and because the end diastolic pressures get elevated. And that's because it's not able to pump as much. The heart isn't able to pump as much out. The blood will tend to back up into the lungs if it's not able to get out in the forwards direction, and that will cause dyspnea or breathlessness. Diabetics and the elderly tend to have reduced pain sensitivity, and you might find that in an elderly person or a diabetic that they might say they feel a bit sick or a bit clammy. They might say they don't feel well, but they might actually not experience any pain and they're having an MI. So you have to watch out for patients, especially the elderly and diabetics, in terms of trying to pick up what kind of symptoms they're explaining. They might not necessarily tell you or feel any pain at all. So the signs are that the patient might be clammy or sweaty, and they may have pallor, and that's just to do with sympathetic responses causing vasoconstriction in the periphery to try and reduce the volume for blood to have to get around into the main organs, and that makes it more easy for the vital organs to get the blood that they need, if you're not having to pump out to the skin and things as well at the same time. So the patient may appear pale because of that. They may be tachypneic or tachycardic. So they may be breathing fast, or their heart rate might be raised. Their heart rate might also be reduced. They might also have bradycardia if they have that. If they have any kind of infarction around the sinoatrial nodal area, or a dissection like I described, that tears and infarcts the sinoatrial nodal area as well. Levine's sign is just, it's not exactly diagnostic, it's not anything especially useful, but it's just something to look out for. And it's quite an old sign, and it was just found that patients who have chest pain that relates to the heart, some kind of angina, they tend to clench their fist and put it towards their chest, and that's supposedly something that is a strong suggester of, or a reasonable suggester that chest pain they're experiencing relates to the heart. It's definitely not diagnostic, but it's just something to look out for. Signs of things that exacerbate the symptoms and the ischemia are things like pallor, which you can get from anemia, and one of the first areas to go pale in anemia is the conjunctivae. So if you look in the conjunctivae, you may see that they are pale. A prominent apex beat, that I think is probably quite hard to tell if you haven't felt the patient's apex beat before and have some sort of baseline to compare it to. But you might feel a prominent apex beat, and that may suggest hypertrophy. There may be a ejection systolic murmur and plateau pulse, which is kind of a harsh, loud murmur that you'll hear best over the aortic area with the stethoscope, and a plateau pulse, which is a pulse that just slowly rises when you feel the patient's pulse, and that relates to aortic stenosis. You might also find that the murmur radiates to the carotids if the aortic stenosis is severe enough. And heart failure as well, you might find signs of heart failure. You might even find signs of heart failure because they're having an MI and they're going into heart failure. So you can listen for basal crackles, which is because of pulmonary edema. You can listen to that at the lung bases and then work your way up to try and tell where that pulmonary edema has gotten up to. It'll start at the base of the lungs and work its way up to the apex, or to the apices, I should say. The JVP might be raised, and that's just because of not enough forward flow, not enough cardiac output going through the heart, which results in that backup that I described causing pulmonary edema. That can go all the way back around into the right ventricle, and that goes even further into the right atrium, and this is starts to get called congestive heart failure. The right atrium then has high pressures, and because blood flows down pressure gradients, it's difficult for blood then to get from the veins, like the jugular vein, into the right atrium. So the jugular vein will be distended and raised above the clavicle. So you might be able to measure the JVP and find that it's raised, and that's a sign that the pressures on the right side are raised, which can be a sign of heart failure. And there are other signs of heart failure as well, so you might find peripheral edema as well as that pulmonary edema. And you might also hear things like an S3 and different sounds that you might auscultate. You might also be able to find that I'll do a talk on heart failure, but you might be able to find that the cardiac borders when you percuss are further out than you would normally find. It should be mid-clavicular line on the left fifth intercostal space. But you might find that it's a bit further to the left than the left mid-clavicular line if they're in heart failure, and that's just because the the heart's beginning to dilate because it can't because the pressures are too high for it to pump into, and the blood's just filling up in the ventricles. So in terms of investigations, ECG is basically the first thing that you should go to if you see a patient with chest pain. You need to find out whether or not they're having stable angina or unstable angina, and differentiate that from an infarct. So you need to know whether or not they're having a STEMI or not, mainly. You need to tell whether or not there's any kind of ischemic changes as well, and ST depression is a sign of ischemia. So ST elevation is a sign of infarction, ST elevation MI, but ST depression is a sign of ischemia. You might also find inverted T waves, which is a sign of previous cardiac event history. And I've put that the ECG tends to be normal in 50% of patients. This is something I accidentally left in from the stable angina lecture, so I'm not sure if the ECG would be normal in 50% of patients that are having a suspected acute coronary syndrome. It's normal in more than 50% of patients that are going through stable angina, but with acute coronary syndromes, I suspect it's different, so ignore that. Coronary angiography is something that you obviously can't do at the roadside or something in an ambulance, but when you get to hospital, it's one of the first things you want to start thinking of doing once you've confirmed that, if you confirm that there's been a STEMI, because the angiography allows you to determine exactly where the stenosis is. You can quantify the stenosis, and then you can decide whether or not and exactly where to go with a percutaneous coronary intervention, a PCI, and that's where you put a stent into the artery and kind of hold it, and that kind of holds it open. I'll talk about those more in the treatment though. So bloods as well are important, and some of these are to exclude other exacerbating factors, and some of them are to help with the differential. So full blood count, FBC, that will help you interpret whether or not there's anemia. Lipids, if the patient has hypercholesterolemia, they are more at risk for heart attacks and and various cardiac events. Fasting glucose. Glucose can be affected by an MI, so this needs to be checked up on. Some patients need to be given insulin. Electrolytes, which can cause rhythm disturbances. Liver and thyroid function tests, L and TFTs. So the TFTs are for the same reason as I explained before, to see if there's any thyrotoxicosis that might be causing or exacerbating the ischemia. And troponins, which are absolutely essential. Troponins help you differentiate between NSTEMI and STEMI, between unstable angina and NSTEMI. If you see ST elevation on an ECG, you basically know that person's having an MI. But if you don't see that, and you don't see ST depression, which you might not, then it can be difficult to tell the difference between unstable angina and NSTEMI. NSTEMI is where there's actually been an infarct, whereas unstable angina is just ischemia, and it's not yet gotten to the stage where it's causing an infarction and even myocyte death. So troponin helps you determine whether there's been myocyte death, and therefore tells you whether or not there's an NSTEMI or unstable angina. Troponins won't be raised until about 13 hours after the event, I think. So you need to wait for troponins to rise and then measure them, and then you'd continue to measure them every so often after that 12 hours to see how long the ischemia is lasting, because that can affect your decisions in terms of treatment. Chest X-ray. This is important to explore other causes in the differential for that kind of chest pain. You can use chest X-ray to see if there's any pulmonary edema. You can also use it to see if there's been an aortic dissection. It's not ideal for an aortic dissection, but it's quick. So you might see in an aortic dissection a widened mediastinum, which might set some alarm bells ringing, and you go through some different investigations to figure out whether or not it is an aortic dissection, which requires different treatment, emergency surgery probably if it's in the ascending aorta. So this is something I'll talk a bit more about in a different talk, but basically that requires a different protocol entirely for an aortic dissection, blood pressure management and so on. Myocardial perfusion scan is useful if you're not sure whether or not the patient's had an infarct. It's not exactly quick like the ECG and the chest X-ray, but it can be useful if it's difficult to figure out what's going on. So this is a radioactive test where you inject a radioactive dye. It's more useful in stable angina, really, I think, because then it can be more difficult to differentiate. But with the acute coronary syndromes, I think it tends to be a bit more obvious. So if there has been an infarct, you'll be able to see whether or not this radioactive tracer is taken up or not. And in an infarct, it won't be taken up by the infarcted region of myocardium. Also, if there's ischemia, you can see that there's less of the radioactive dye, the tracer, taken up on the scan. It's a stress test, so you can pharmacologically or in way of exercise stress the patient to increase the heart rate, and then you will see whether or not the take up of this tracer is changed. And if that changes, that's because you've induced some ischemia with the stress. So that can be a useful diagnostic test, but in acute coronary syndromes, you tend to go for the very quick options, which are those first four that I've listed. So the differential is quite complicated. There's lots of different things that could be going on when someone says they have chest pain. You have to really explore what the nature of the chest pain is, and do your kind of history and physical exam all very quickly. So unstable angina, NSTEMI or STEMI, I've already talked a bit about telling the difference between those, and it's based on the patient's history as well as on the ECG and the troponin. Shingles is a viral is from varicella zoster, which invades the nerves from someone that's had chickenpox much later in life. It comes out from the nerves and it causes I'm not sure if it comes out from the nerves actually, but it's related to the nerves, and it causes a rash, a very painful rash, wherever it spreads, and it spreads in the regions of the dermatomes. So that can cause chest pain. So can viral mastitis, musculoskeletal pain from Coxsackie infection, or for example just from exercise. You might have pain in, you might have strained your intercostals from breathing heavily because of exercise. Bone pain, costochondritis, or cancer, metastases from cancer into the bones, or fracture of bones, fracture of your ribs can cause chest pain. Gastroesophageal reflux disease. This is important to differentiate from the quite different diagnosis, the quite different symptoms and signs of the acute coronary syndromes. And this is more like an epigastric and sort of upper sternal region burning pain, but I'll talk about that more once I get onto GI. So the pleura can cause chest pain as well. The pleura have sensitivity to pain. They have sensory nerves in them. So pleurisy, which is just inflammation of the pleura, pleural effusion, pneumonia, pulmonary embolism, and anything else that can cause any of these things, like pleurisy or pleural effusion, can cause chest pain. Peri or myocarditis. These two things might come on after an MI. For example, Drester's syndrome, which is an autoimmune disease that comes on a couple of weeks after an MI, tends to come on about a couple of weeks after an MI, causes this kind of pleury and pericarditis. So you get an inflammation of these two things, and that can also cause chest pain. Aortic or coronary artery dissection, like I talked about, these tend to be described a bit differently by the patient. So an aortic dissection tends to be described apparently as a sort of tearing pain, which can radiate to the back. So you've still got a retrosternal pain, but it's tearing and extremely painful, and it tends to radiate to the back, and it can come on extremely suddenly. The blood pressure might be different in both arms, because if you think about it, if it's in the aorta and with the two brachiocephalic arteries coming off from different places, if the tear is in between those, you'll get different blood pressures in either arm. If the tear goes into the right coronary artery, into the sinoatrial nodal artery, then you can get a bradycardia. And if the tear goes towards the aortic valve, you can get aortic regurgitation, pulmonary edema as well, and poor peripheral pulses. So referred gut pain can also be sort of confused with chest pain. So let's go on to the initial management, and this is for STEMI. So if you do an ECG and you find someone has ST elevation and they're going through chest pain, then pretty much the first thing you want to do is give them oxygen and titrate this up to around 90%. I'm still a bit confused about the NHS says to give the patient oxygen. I'm still a bit confused physiologically how the oxygen helps, because as long as their lungs are working fine, then they should have enough oxygen saturation in their blood. If there's any kind of difference because there's no problem in diffusion of oxygen across the lungs in an acute coronary syndrome, unless there's pulmonary edema, in which case I completely understand why you'd want to give them oxygen. So there are slightly different guidelines depending on where in the world you practice or study medicine or study whatever you're studying, and giving oxygen is sometimes said to be done only if the patient has hypoxia, whereas other guidelines say if someone's having MI or an acute coronary syndrome, you give them oxygen no matter what. So, unless of course there's some kind of contraindication. So that can vary a bit. But generally, if they have hypoxemia, you definitely want to give them oxygen. Aspirin and clopidogrel are the two antiplatelet drugs that you need to give. Aspirin is the immediate thing, one of the very first things that you need to give during an acute coronary syndrome. If you give it to someone who's having an MI, it saves about 23% it reduces mortality by about 23%. So that's a really big deal to just give them an aspirin. A PCI should be done. PCI is like the ideal therapy for an MI. So if someone's having an MI and you manage to get them to the hospital in under 12 hours since the event, or you get to them to the hospital and there's still ischemia going on, which is why you need to keep on checking the troponins, then you give them you send them to the catheter lab, and experts and cardiologists will do a PCI on the patient. This means that they put a stent into the coronary artery where the occlusion is, and that holds open the coronary artery. Ideally, that stent is drug-eluting to try and it elutes drugs which try to reduce the potential for the coronary artery to once again occlude. So those are things like anticoagulants. If a PCI is contraindicated, then you can do thrombolysis, and you can use drugs like streptokinase or alteplase for that. Alteplase you can use as many times as you want. Streptokinase, the body makes antibodies to streptokinase after you've used it once. So you can only ever use streptokinase once. So if you don't know whether a patient's had it or not before, it's best not to give it, because it might not work if they've ever had it before. And a coronary artery bypass graft is an alternative to PCI if you're failing to revascularize the patient and there's still ischemia going on. So another thing that you want to give whilst you're sort of on the scene with the patient is nitrates, glycerol trinitrate or nitroglycerin, and these help to reduce the preload and the afterload. By reducing the afterload, you manage to make it easier for blood to flow down that pressure gradient out of the heart. If the heart is not managing to pump well because the myocardium isn't able to function very well, isn't able to pump as hard, then it's not able to generate as much pressure. So it's not able to increase the pressure in the ventricle to get it out into the periphery where the pressure is lower. So you can reduce the pressure in the periphery to make it more easy for that blood to flow out of the heart. Analgesia is important not just for relieving pain, but it also does a few other things if you're giving an opiate. So if you give an opiate like morphine, this doesn't just reduce pain, which is obviously very important as well, but it also reduces the pressure in the pulmonary vasculature because it dilates the pulmonary vasculature, and it also reduces the heart rate, which you need to be careful of if the patient's having a bradycardia, but if they're not, that reduces the potential for ischemia because it reduces the demand for oxygen of the myocardium. And by dilating the pulmonary vasculature, you increase the flow from the pulmonary vasculature into the left atrium, so you increase the potential for forward flow and reduce pulmonary edema. So that can really clear up the lungs if someone's in acute pulmonary edema. Initial STEMI treatment, sort of a continuation from before. Low molecular weight heparin is something that you should give as soon as possible because it reduces the potential for any more thrombotic events or any more thrombotic events or emboli forming. So you don't want someone to have another MI whilst they're already having one, and it's possible that if they've had a ruptured plaque which has caused the MI, that ruptured plaque might still be very unstable, and there's potential for more of that plaque to break off and get itself wedged deeper down in the coronary in the coronary arteries. Beta blockers are something that you want to consider within the first couple of hours, really, and I think it's within the first 90 minutes, ideally, as long as the patient doesn't have a bradycardia or hypotension or heart failure. If they have heart failure, it's a bad idea because, and this is acute heart failure I'm talking about, it's a bad idea because it reduces the ability of the heart to undergo sympathetic increases in pumping ability and heart rate, so it reduces the cardiac output. And if you reduce the cardiac output too much, if it's already reduced and that's causing acute heart failure symptoms, then you can cause pulmonary edema that's severe enough to be very threatening. So beta blockers are a very good thing to give. They reduce the workload of the myocardium, the oxygen demand. They also mop up reactive oxygen species from myocytes. And because they reduce the heart rate, they increase the time for coronary artery perfusion, which is in diastole. If the patient has a bradycardia and you're not giving them beta blockers, you give them atropine to speed up the heart rate. And if they have a high cholesterol, this is kind of something that you would give for several years after I think it's 3 years after the event, maybe more, which is statins and fibrates. So statins help to reduce the endogenous production of cholesterol by inhibiting HMG-CoA reductase in the liver, and fibrates help to reduce the absorption of cholesterol in the diet. I haven't got a slide on here for NSTEMI because NSTEMI and unstable angina, because they are treated very similarly to STEMI, except for the revascularization process. So in unstable angina, unless that unstable angina is completely uncontrolled in terms of symptoms with drug treatment, then you wouldn't really consider PCI or coronary artery bypass graft or CABG. Whereas in NSTEMI, you do actually have an infarct, so it is reasonable to consider revascularization, but it's not sort of so automatically assumed as in STEMI. It's a little bit more complicated in that you need to assess their condition on a risk score of another event occurring, and if they're medium to high risk or something, moderate to high risk I think it is, then you give them a coronary angiogram and you look to do a PCI or CABG. Whereas if they're low risk, you treat them therapeutically with something like thrombolysis. So that's a little bit more complicated, and I don't completely understand it compared to STEMI, which is basically just everything you can do, you go for. So after the initial panic of the MI, or the treatment for any of the acute coronary syndromes, then you want to give ACE inhibitors because they help to reduce the potential for ventricular remodeling. So the left ventricle or the right ventricle, if they aren't able to pump as well and they can't generate that pressure very easily to pump into the periphery, into the aorta or the pulmonary vein or the pulmonary arteries or the pulmonary artery, then the problem can be that the ventricles have to compensate by dilating in order to generate enough pressure to get the blood out into the periphery. They can't hypertrophy anymore because they're already too damaged to hypertrophy. So that if the heart dilates, it's difficult to get it back to normal, even if the myocardium function improves over time. So reducing the blood pressure with ACE inhibitors is useful. You should also modify the risk factors by giving things like statins and fibrates for cholesterol, treating any hypertension, which I'll talk about which I talked about in a different lecture, a different talk. Exercise is good. Getting some exercise, getting a bit fitter, and looking into the diet as well and making sure that there's as little cholesterol in there as possible. Obesity and diabetes, trying to control those. Diabetes is a major risk factor, as is hypertension and cholesterol. All of these are, but diabetes is particularly important because it causes changes in the vasculature that promotes inflammatory responses that lead to atherosclerosis, and that atherosclerosis leads to the potential for plaque rupture, which leads to MIs. So that's important to control. If diabetes is present, then just making sure that that patient has well-controlled diabetes is extremely useful. And smoking is never good either. That reduces the blood oxygen levels and raises the heart rate and the demand of the myocardium. And it causes several problems, as well as various other things that it's bad for, like lung cancer and COPD. So beta blockers have quite a few contraindications. If they're given after an MI, which they should be if there's no other contraindications, then stopping them all of a sudden can cause a rebound MI. So never stop beta blockers suddenly, they have to be weaned off. They shouldn't be given in asthma because beta 2 receptors need to be... There's already bronchoconstriction in asthma, and the inhalers that people take with salbutamol in for asthma is a beta 2 agonist, which helps to dilate the bronchioles. If you give beta blockers, which have some beta 2 antagonist activity, they'll cause bronchoconstriction. So they are contraindicated in asthma because bronchoconstriction is already a problem to begin with. Raynaud's, unstable heart failure or heart block, those are all other contraindications. Raynaud's is because of poor circulation to the digits, the fingers on the hands or the feet, and if you give beta blockers, that can worsen that. That can reduce peripheral circulation to those regions. So side effects from beta blockers are things like fatigue, lethargy, impotence, bradycardia and bronchospasm. So the last two are ones that I mentioned a few times. Bradycardia, because they can cause bradycardia, you never really want to give them in a bradycardia or during hypotension, and you don't want to give them during bronchospasm because they will cause bronchoconstriction. The effects from other things that do similar things to beta blockers, like calcium channel blockers, can be additive. So you don't really want to mix beta blockers and calcium channel blockers unless calcium channel blockers earlier on in something like hypertension haven't been effective. In which case you keep the calcium channel blockers, but you very carefully at a low dose add the beta blockers. So NSAIDs, they antagonize the antihypertensive mechanisms of beta blockers. I don't have any idea how they do that, but apparently they do. And they can also mask hypoglycemia. And finally, aspirin and calcium channel blockers. Like I said about aspirin, it's one of the main things that you want to give immediately when someone's having an MI. But it's also, I think, the major cause for admissions of GI bleeds in hospital. So that needs to be that has to be considered as well if someone comes in and they're on aspirin and they're having a GI bleed. And calcium channel blockers can cause ankle edema, and that ankle edema doesn't always respond to diuretic therapy. So that can be an extremely unwanted side effect of calcium channel blockers. And that's it. So thanks for listening, and I'll look forward to talking in the next one. Let me know what you think, and if you have any advice for the ways that I could do this differently, or a different way of presenting it maybe, then just let me know. Okay, bye.